Okay, it's a little bit after 2:30, so I think we'll get started. Hello, everyone, and welcome to the Healing Community Study Learning Collaborative. My name is Lisa Romley, and I'm the Education Program Coordinator for the HEAL Study. We are here today to discuss and learn effective strategies for buprenorphine dispensing. Today's speaker, let me move my slide here, has worked tirelessly to advance pharmacy practice in Kentucky. Her accomplishments are numerous and will take maybe most of today's session if I had to list them all. So just to highlight a few of them, she is the principal investigator on the Kentucky Opioid Response Effort with the Vivitrol grant. She is a co-investigator for the NIH initiative HEAL Study. Dr. Trish Freeman is the Earl Platt Sloan Endowed Professor in Pharmacy Practice and Science and holds several positions at the University of Kentucky College of Pharmacy, including Director of the Center for Advancement of Pharmacy Practice, Professor in the Department of Pharmacy Practice and Science, and Faculty Associate in the Institute for Pharmaceutical Outcomes and Policy. She has received a bachelor degree, a pharmacy degree, and a PhD from the University of Kentucky, and completed a postdoctoral fellowships at the University of Vermont College of Medicine and the UK College of Medicine. We are very excited to have her here today presenting, as well as the panelists, Dr. Jill Rhodes and Dr. Chris Harlow, which Dr. Freeman will be introducing later on in the session. So before Dr. Freeman gets started here, I do want to give just a few reminders that this session is being recorded today. We are offering CE credits, and one CE credit has been approved for physician, pharmacist, nurses, social worker, and licensed drug and alcohol counselors. I will give you some information at the end of the session on how to obtain that CE credit. We ask that you stay muted throughout the session, and that helps reduce the echo and extraneous noises. If you do have any questions, and we do welcome your questions, we ask that you use the raise hand feature. You'll find that at the bottom of your screen. You click on reactions and then click on the raised hand. You also can put the questions in the chat box, and I know Dr. Freeman will be reading those during the roundtable discussion. So I am going to stop sharing now and turn it over to Dr. Freeman.
Here. Okay. Can everyone see my slides okay now?
Yes.
Right. Well, thank you so much, Lisa, for that introduction. Those are always a little embarrassing to me. I've been around pharmacy world in Kentucky for a long time, so I know a lot of folks that are on the call today, and I just want to say thank you for joining us this afternoon as we really share some of the work we've done around buprenorphine access in pharmacies. So I have a few of these disclosure slides. I don't have any relevant personal financial relationships to disclose. We do have a couple results from a couple of studies that were funded by the NIH that I will mention as we go through the talk today. And I think it's important to know that this is an important issue to be discussing today, because one of the key advantages to buprenorphine is its accessibility, right? I mean, we're able to prescribe it in office-based addiction treatment programs, and individuals who need treatment with buprenorphine for their opioid use disorder, they can take those prescriptions and get them filled at our community pharmacies. And so that's just really a strength of this as a medication treatment for opioid use disorder. However, we have emerging evidence that suggests there are some barriers at the pharmacy level that are limiting access to the treatment. And so we really want to try to think about why we have those barriers, what those barriers are, and what would be effective strategies perhaps for overcoming those barriers. And so those are really the objectives that we have today. I will start by just, reminding everybody briefly about some of our clinical guidelines for buprenorphine treatment for opioid use disorder, and then briefly review some of our administrative regulations that govern buprenorphine prescribing here in Kentucky. And so then the last session, as Lisa said, will really be a roundtable discussion. You know, we're going to talk about some literature, and then I'm going to introduce, and some of the work we've done, then I'm going to introduce our panelists, and we really talk about practice and what are the barriers that we see in practice, and how we might effectively overcome those. So as Lisa said, if you have questions as we go forward, please put those in the chat. And then we'll bring those questions forward in the last half of the session. All right, so by way of an introduction, I just want to remind everyone that opioid use disorder is recognized as a chronic disease. And when we talk about chronic diseases, you know, really, you know, they have common features, right? I mean, they're long in duration. They're associated with persistent recurring health issues. Chronic diseases oftentimes have a mixture of causes, but there's usually some heritable component that underlies that chronic disease. They have no definitive cure most often, and really I think of utmost importance is that all chronic diseases require ongoing care so that we can keep people as healthy as possible in the setting of having that chronic disease. And so currently, all of our guidelines recommend medication as the primary treatment for opioid use disorder, the chronic disease of opioid use disorder. So I'm just going to briefly review these. And so this is a slide that's just summarizing some key points from the most recent ASAM guidelines. These were published in 2020. And I've highlighted in red some of the statements I think that are pertinent for us to focus on as we think about the treatment of opioid use disorder as a chronic disease. So the guidelines specifically state all FDA approved medications for the treatment of OUD should be available to all patients. They go on further to say that there's no recommended time limit for pharmacologic treatment. And while psychosocial needs should be addressed, a patient's decision to decline psychosocial treatment or the absence of available psychosocial treatment should not preclude or delay pharmacotherapy with appropriate medication management. So I wanted to point this out because, you know, historically, and when buprenorphine first came on the market and we started talking about medications for opioid use disorder, you know, we referred to buprenorphine as a medication to assist in the treatment, or MAT, medication assisted treatment. And so when you look at these new ASAM guidelines, what this is really telling us is that, you know, we don't say that our antihypertensive are a medication to assist in the treatment of hypertension. We say our antihypertensives are medications to treat high blood pressure or hypertension. And so we really need to be viewing the buprenorphine and other medications for opioid use disorder in this same light. So throughout the presentation, you will notice that we do not use the term MAT, but really refer to MOUD as a reference to this. So these are just some additional guidelines I skipped over. The World Health Organization, similar to what we see with the ASAM guidelines. Pharmacologic treatment should be accessible to all those in need. Most patients should be advised to use opioid agonists medication, and we'll go into a little bit more detail about agonists versus antagonists as treatment in just a second. And then finally, again, those who do not take up the offer should not be denied effective pharmacologic treatment if they do not take up the offer for psychosocial services. And then finally, our Substance Abuse Mental Health Services Agency, this is from tip 63. Ongoing outpatient medication treatment for OUD is linked to better retention and outcomes than treatment without medication. And they go on further to say that medication treatment may include lifelong treatment. And so these are really some of the newest features that have put into context that we should really be focusing on opioid use disorder as a chronic disease and treating it with medications similar to how we use pharmacologic agents to treat other chronic disease. So currently, there are 3 FDA-approved medications for opioid use disorder. And went a little bit too far ahead, excuse me. And so while the purpose really today is to focus on buprenorphine, I am going to, briefly mention methadone and naltrexone just so that we can, compare and contrast a little bit before we shift really the remainder of the conversation to buprenorphine. So when we look at the FDA-approved medications, methadone and buprenorphine are both classified as agonists, meaning that they activate the opioid receptor. Methadone is a full agonist and can activate that receptor fully, and is a highly regulated Schedule II controlled substance that is only available for the treatment of opioid use disorder in the context of federally regulated opioid treatment programs or opioid treatment centers. In contrast, buprenorphine is a partial agonist and partially activates the opioid receptor. And so it has a ceiling effect, and you will not fully activate that receptor like you do with methadone. Because of that ceiling effect, it does have a lower risk for overdose. It also, because it's not as, does not have the same potential for addiction as methadone and some of our Schedule IIs, and the same potential for diversion, it's classified as a Schedule III controlled substance in Kentucky and in the nation. And one of the features about buprenorphine, which everybody is aware of, is that it really, needs to be prescribed by a qualified practitioner who has applied for and been granted a waiver to provide addiction treatment outside the opioid treatment program setting. So in contrast to these 2 agonists, naltrexone is an opioid antagonist and actually physically blocks the opioid receptor and then prevents the opioid agonists that an individual might be using from interacting with that receptor. And so it actually serves to physically block the receptor. And because of that, if an individual has opioids, is using opioids currently, and were to use naltrexone as a medication for opioid use disorder, it could precipitate withdrawal. And so because of that, the current treatment guidelines, individuals have to be free from opioid use for 7 to 10 days so that we do not precipitate a withdrawal syndrome when the naltrexone is administered. And this is one of the reasons why in some cases it's a limitation of treatment, because an individual has to go through that period of opioid abstinence before they're able to access and successfully use that medication. So this slide it's kind of busy, I know, and you'll get these slides afterwards and you can take a look at it, but I just wanted to highlight sort of, a summary of what we know about buprenorphine as a medication for opioid use disorder. It has proven efficacy. It reduces withdrawal, it reduces cravings, manages cravings, reduces opioid use, it increases retention in treatment, and most importantly, it decreases mortality. It saves lives. And so there are numerous products and formulation on the market, including our transmucosal products, which are the most commonly used. We also have long-acting injectable forms of buprenorphine. Those are not dispensed routinely in every pharmacy, but are dispensed from specialty pharmacies. And we can talk a little bit more about that later in the session as needed. But the transmucosal products of buprenorphine, the combination products of buprenorphine and naloxone are really the most commonly used. The buprenorphine monoproduct, transmucosal product, is available, but is reserved for patients who are pregnant or who have documented hypersensitivity to naloxone. It's really beyond the scope of today to go into a lot of detail about dosing and induction and things, but generally speaking, the dose of buprenorphine will vary based on the phase of treatment that the patient is in, and also just the patient's individual needs. Higher doses up to 16 milligrams, and in some cases up to 24 milligrams if it's needed for the individual patient situation, may be more effective than lower doses. But we have prescribing regulations that we'll talk about in just a bit that provide guidelines for clinicians to follow. And so we mentioned this X waiver, and so pharmacists are able to verify if a practitioner has an X waiver or X license by actually using this SAMHSA lookup tool. And so you can see that I've posted the link to that SAMHSA verification lookup tool for your information after you leave today's session. We'll get these slides to you. So I'm going to switch gears now, and we're going to talk a little bit about the prescribing regulations, 201 KAR 9270, which are our KBML or Kentucky Board of Medical Licensure regulations, and 201 KAR 20065, which are our Kentucky Board of Nursing regulations. For illustrative purposes, I'm going to just go through the KBML regs. The KBN regs are very similar to the KBML regs. And so we'll just talk briefly about what's contained in these regulations. So these regulations have set forth standards for physicians and soon to be physician assistants who have recently received authority to prescribe controlled substances in Kentucky, the professional standards for them to prescribe and dispense buprenorphine. And so the professional standards have numerous sections, and in these sections, they outline a variety of different requirements, such as the need for the X waiver that we've already mentioned, the need for initial education that you need to have when you apply for the X waiver, and then continuing professional education in the treatment of addiction that's required if you're going to continue to prescribe and dispense buprenorphine. The use of the Kentucky Health Information Exchange. It provides, the regulations provide guidance on the mono product and when the mono product can be prescribed, and guidance on when there can be concurrent prescribing of sedatives and benzodiazepines, for example, gabapentin. They give guidance on how patients should be assessed and how prescribers should utilize CASPR before issuing prescriptions for buprenorphine. They provide guidance on the dosage, the frequency of taking those dosage once a day, twice a day, the frequency of administration, the day supply that can be prescribed in the early phase of treatment, and then when treatment is ongoing, and then a section on monitoring, including the need for regular urine drug screens and pill counts, and then finally guidance on how the care that these X-waivered prescribers are providing to the patients, how that care is documented to ensure that these standards are being met. And so they're very comprehensive. And even though I'm going to show you, we have one additional section, the section 4, subsection 2 of the regulation actually has some leeway, what we call a catch-all statement, that if a physician is unable to conform to the standards that have been set forth in the regulation up to this point, due to circumstances that are outside the physician's control, or if the physician makes a determination professionally that it's not appropriate to comply with the standard based on that individual patient's diagnosis and treatment, then the physician can document those circumstances and can prescribe or dispense buprenorphine outside the KBML guidelines, as long as that prescribing remains in accordance with the SAMHSA guidelines. Okay, so we have these regulations, but then we also have the ability in these regulations for those prescribers to make individual decisions. But I think what I will say, and what I think practitioners that are on the call with me will recognize, is that when we have such regulations that are so explicit, that unfortunately these types of regulations can have a chilling effect. Can have a chilling effect on pharmacists, physicians' willingness to prescribe in the first place, and a chilling effect on pharmacists willing to dispense. And sometimes people get confused about this because they're like, the physician is the prescriber, they're making the prescribing the decision, and it's the pharmacist's job to fill the prescription that the physician has written. But the DEA and the manual for pharmacists that the DEA puts out it actually states, and it makes it very clear that pharmacists have a corresponding responsibility. And in fact, what I'm gonna see if I can state this exactly so I don't misquote the DEA. Although the responsibility for the proper prescribing and dispensing of controlled substances is upon the prescribing practitioner, a corresponding responsibility rests with the pharmacist who fills the prescription. An order purporting to be a prescription issued not in the usual course of professional treatment is not a prescription. And therefore, the person knowingly filling such a purported prescription shall be subject to the penalties provided for violation of controlled substance law. So putting that into context, what this sets up is a legal environment in which there is a chilling effect and fear on the part of a pharmacist that they're going to fill a buprenorphine prescription that in fact could be misconstrued as being outside the regulations and therefore not a legal prescription, and they have a corresponding responsibility. We will talk more about this in the second part of the session today, but I just want to briefly point out that because of this and because the pharmacists have a corresponding responsibility, the Board of Pharmacy has put together really some FAQs trying to answer buprenorphine questions for pharmacists to try to help them feel confident in dispensing prescriptions that are actually legal and meet all the requirements of the regulations. All right, so that gave us a little overview of the guidelines, an overview of the regulations, and so now I want to really kind of delve in to this barrier issue. We first heard about barriers anecdotally in the lay press starting 3-4 years ago. Articles working with pharmacies on buprenorphine access. On the right, you can see a morning edition. This is a morning edition spot. It's the go-to drug to treat opioid use disorder. Why won't more pharmacies stock it? And so about the time that we were hearing these anecdotal stories, colleagues of mine, Dr. April Young and Dr. Hannah Cooper, were conducting qualitative interviews with pharmacists in 12 Appalachian counties as part of a study funded by NIDA called Care to Hope. And in these interviews, a couple of things became apparent. First, many pharmacists reported not stocking buprenorphine. And when they were trying to understand why they did not have buprenorphine, some of it was related to stigma. I mean, stigma was evident in these interviews. Some of it was related to mistrust because of the opioid crisis and the overprescribing with OxyContin that had happened in the pain clinics. And so there was some prescriber distrust. But the other thing that really became apparent in this study was that pharmacists perceived that the DEA had set a cap on the amount of buprenorphine that they can dispense. And so Hannah, Dr. Cooper and Dr. Young reached out to me at this time and said, what is this DEA cap on buprenorphine? Can you help us understand? We don't know anything about it. The pharmacists are telling us about it. So the question is there really a cap on the amount of buprenorphine that a pharmacy can dispense? And so what I'll say is that, the DEA doesn't really set a cap. It's not exactly. But what's happened is that there's a rule that's been around for a long time, requires wholesalers to report suspicious orders of controlled substances to the DEA. And when they don't report controlled suspicious orders, and many didn't for a long time, even though this regulation has been in effect since 1971, this indiscriminate dispensing and sending of OxyContin to pharmacies in Florida resulted in huge fines to the wholesalers. And in response to these fines, and the DEA telling the wholesalers, you should have known that those were suspicious orders coming from the Walgreens in Florida. And so what the wholesalers did in response to these fines is they actually set up systems where they put algorithms in place that help them identify suspicious orders. And so with these algorithms, they basically say this is a threshold of buprenorphine that you can order. And if you surpass that threshold, we're going to flag it as a suspicious order and we're going to report it to the DEA. And in fact, they brag about this on their website. This is a statement from one of the 3 primary wholesalers. Our anti-diversion team establishes the threshold limits. When a customer order hits the threshold, the order is held, it's reviewed, and typically canceled. Canceled orders are always reported to the DEA and state regulators. So you can imagine the chilling effect this would have on pharmacists. I don't want to surpass this threshold, whatever it is. And so I'm going to, limit my dispensing of buprenorphine, or I'm not going to dispense buprenorphine at all. And so we decided from a research standpoint, we set out to see if this was really an issue just in Kentucky or an issue nationally. And so we did a survey of independent community pharmacy members of the National Community Pharmacists Association. And we surveyed, depending on the question, we had over 450 that answered a variety of questions. They were voluntary, so the N changes on each question. But as you can see from this slide, they were aware of wholesaler thresholds and used various tactics to manage them. And so I've highlighted some of the important ones here that could impact access to buprenorphine. So I've limited the filling of controlled substance prescriptions to known patients. I've limited the filling of prescriptions to known prescribers. I've limited the filling of prescriptions to patients with local addresses. I made a decision not to stock a certain substance. Okay, so almost 20% of the respondents said that. I declined filling legitimate controlled substance prescriptions, almost 40%. So you can see this is not just a problem in Kentucky, but nationally. And in fact, when we asked the question specific to buprenorphine in this survey, do you dispense buprenorphine products for the treatment of opioid use disorder at your pharmacy? 12% of the respondents said no. And when we asked the second question, for those that said yes, we said, well, you dispense it, but is it available to all new and established patients with a legitimate prescription? And 17% said no to that question. So when you add this up, what this means is 3 in 10 of our respondents indicated that buprenorphine was not fully accessible to all patients that had a legitimate prescription at their pharmacy. So we were, not surprised. I mean, we were a little surprised that the number was so high. But in this survey, we also tried to assess stigma and the impact of stigma. And so what we did, we had 2 questions that really helped us sort of parse pharmacist respondents into 2 categories, stigmatizing attitude categories and a non-stigmatizing attitude category, if you will. And so a question like buprenorphine is trading one addiction for another. And so if pharmacists answered agree or strongly agree to that question, then that's a stigmatizing attitude and they would fall into the stigma category. And so when we stratified the dispensing behaviors of pharmacists by the presence of these stigmatizing attitudes, what we saw is that 40% of pharmacists who fell into this stigma attitude category, 40% of them said they did not stop buprenorphine. So there's complex issues going on here, and we continue to work on this, both our research team here in Kentucky, but also other teams nationally are looking at this. And so since we've done our work in the 12-county Appalachian area, this is in Texas, availability of buprenorphine. They did a similar secret shopper in New York City. And in both of these studies found that between 40 and 50% of the time, pharmacists, when they made these calls, pharmacists did not have buprenorphine in stock or would not be willing to fill a buprenorphine prescription that same day. This just came out recently, Coate and his colleagues, and again reinforcing this DEA disconnect that we published first in the International Journal of Drug Policy last year, and how it's leading to buprenorphine bottlenecks. So I want to now just turn to what we know from practice, and I'm going to stop and we're going to introduce our panelists. We have two really distinguished panelists that are with us on the call today. And so I'd like to introduce to you Dr. Jill Rhodes and Dr. Chris Harlow. I have known and worked with Jill and Chris for many years, and both are highly motivated and extremely passionate pharmacists and public servants. They have a substance use disorder pharmacy practice in Louisville, Kentucky at St. Matthew's Community Pharmacy and specialty pharmacy practice at St. Matthew's. And then they both actually serve on the Kentucky Board of Pharmacy, with Jill currently serving as the president of the board. So I want to welcome Jill and Chris and just ask you at this point, if you would like to just, introduce yourselves and sort of just say a few words about your practice. Jill, you want to start?
Yeah, absolutely. Thank you so much, Dr. Freeman. I really appreciate the time today and the invitation to speak at this, presentation. I'm a Kentuckian. I'm actually from Eastern Kentucky. I grew up in Paintsville, and this is an area that's near and dear to me. I started as an oncology specialist and still am, but as the Commonwealth and as this issue has grown of concern, you go where the need is. And so we have developed a practice at St. Matthew's with my partner, Dr. Harlow, in looking at how we can fill the gaps in care. And it's been tremendously rewarding and challenging as we have jumped through hoops and through the river and over the hill in order to get things to the people that need it the most. And, we still continue to do that. And we're very passionate about that, as well as the wraparound services. Did my training at the University of Kentucky. And so homegrown, here to stay. And, I'm just really happy to be able to represent the Board of Pharmacy today and answer any questions that you may have as it relates to access to therapy.
Thank you, Jill. Chris?
Thank you, Dr. Freeman. My name is Chris Harlow. I'm from Louisville, and went to University of Kentucky College of Pharmacy and did an additional year of training in community pharmacy with University of Kentucky College of Pharmacy and American Pharmacy Services Corporation. Addiction really did hit me personally. My mother passed away from an accidental overdose while I was in pharmacy school, and I've done a lot of reflection over the years, thinking about how I can utilize that experience to make a difference in the communities that we serve. And I have worked both locally and nationally addressing these issues, particularly barrier issues. So I can't thank Dr. Freeman enough for the work she's doing and putting forth this educational programming. To me, this is an important step in ensuring equitable access to addiction medication and care. I currently serve as Director of Pharmacy Services for St. Matthew's Community and Specialty Pharmacy and National Director of Pharmacy Services for Cordant Health Solution. Cordant Health Solution, they really provide innovative tools and services for substance use disorder, behavioral health, both on the lab and pharmacy side. And then St. Matthew's Community and Specialty Pharmacy has really been a leader in addiction care since we started our pharmacy. And we were the first pharmacy in Louisville to have a signed naloxone protocol, being able to dispense naloxone without a prescription, and the first pharmacy in Kentucky to have a signed board-authorized opioid use disorder protocol. And we started that in 2018, focused on the non-opioid option treatment with the Vivitrol. So again, I thank you very much for the opportunity to be here.
All right, so to get our conversation started for the roundtable discussion, and again, to members of the audience, I have some questions that we have, that folks have sent in, and I have some questions that I have prepared for Jill and Chris, Dr. Rhodes and Dr. Harlow to respond to. But I want to just kind of set this up to start the discussion. So this is a patient experience. The patient is seen in the ED and agrees to start buprenorphine. They go to the pharmacy to get the prescription filled, and the pharmacy does not have the medication in stock. And so I guess what I'd like to ask you, you guys, is to respond a bit, to help us understand from practice, what the workflow is and how and where things can get bottled up, why doesn't the pharmacy have the medication in stock? Maybe other reasons in addition to what, we've talked about today. So where do you see the bottlenecks occurring in the buprenorphine dispensing process?
Sure, I'm happy to start here. I think it's important to realize a couple pieces here. And to your point, Dr. Freeman, there could be other things going on within that pharmacy. For example, they may not have it in stock because they've never dispensed it before, right? It could be a new pharmacy, and maybe they just never had a patient with buprenorphine. But I will tell you that that's not really an excuse, right? So we need to be sure that pharmacies are prepared with having this equitable access. One of the things that I think it's important to note is that pharmacists are healthcare providers, right? So we are also involved in the care of that patient, and we must have, and I think we're going to talk about shortly, that collaborative relationship with the healthcare providers, the other healthcare providers that the patient's being treated by. Luckily in Kentucky, we don't have the issues of prior authorizations, right, under Medicaid. There may still be prior authorizations on the commercial side based on the way that the law has rolled out, but that has always been in the past one of the bottlenecks that have affected workflow. So it could also just be that there is the things that we've talked about, the reasons they don't want to stock it for the reasons that we've talked about, which are not appropriate.
I did put up this slide because we do have non-pharmacists in the audience today, and I thought that we might have this slide to kind of summarize the workflow because not everyone might be familiar as pharmacists are with all these steps and the different places where things can get held up, right?
Absolutely. There are many different little stopping points within these arrows from jumping from one task to the next. And, I'll just mention one thing about stock. So, it's not required that a pharmacist or pharmacy stock every drug that a patient may come in. And it may be a choice that pharmacy has chosen not to, stock that particular drug for a variety of reasons. And one may be because it's, not a financial incentive for them. Some products you cannot get reimbursed, and where it is where you actually make any money to dispense that drug. And I think that's important to understand from just a financial standpoint, and looking at why is it not required? A pharmacist has the ability to refuse a prescription if it's within their professional judgment, or if they're out of stock, and they do not have to order that product if that's something that doesn't work for their business model. But moving on, I think that, by and large, people want to, and pharmacists certainly want and desire to be part of this solution. And more pharmacies, I believe, are stocking buprenorphine containing products in order to meet the needs of our patients. So let's say you're at that prescriber writes a prescription. So let's stop right there. It's received by the pharmacy. It may or may not be a patient that pharmacy has a relationship with, or a relationship with you as a provider. There are a few elements on that prescription that really need to be included, that sometimes are not included. So for a buprenorphine prescription, your XDEA, your address, telephone number, how to reach you. Sometimes just stopping there and making sure that we have the information as the pharmacy in order to reach you to clarify anything is really important. The second, patient address, very important. So where do they live? Do we have that information? Are they transient? Because those are things that we are required by law as professionals to report. And so looking at some of those items up front, and making sure that you have all of those elements on the prescription that are required by law by both the prescriber and the receiving party on the other end is important. If you don't have a relationship with the pharmacist or that pharmacy, or that patient pre-existing, that may be something that you could work through to develop that relationship if you're going to be sending prescriptions to that pharmacy, so they know that you're going to be sending those to them, what the products are that you'll be prescribing. And then there's a trust and a professional development that can occur and that line of communication that makes it so much easier to clarify certain things. Now you're doing a Casper report on the patient. So, social security number is important. So if we have individuals who don't have a social security number, that's a stopgap right there, because we cannot do, in the state of Kentucky, that prescription drug monitoring program requirement to evaluate, is this patient receiving more than one product? Is there a concern of, concurrent use of benzodiazepines or other drugs that could cause respiratory depression? And so if that is identified, then, the pharmacist is going to have to clarify that. And so we can talk about that for a minute, or I can stop there. So as to which pit are we going to fall into first? So it's not, it's not a quick prescription to fill. Requires, double counts, or it should, making sure that we're prescribing, we're dispensing the appropriate product and doing it safely in compliance with DEA and state regulations and statutes.
So Dr. Rose, I mean, in listening to you, lay some of these areas where there might be, stops. I mean, because there's a lack of information. I mean, what's some ways that, you mentioned communication. I mean, can you or Dr. Harlow give us a little more, like, what's your vision for how you would communicate, more seamlessly, so that you could provide better care to your patients?
Well, ideally, if you're developing a practice and you're working within that community, I think that the pharmacist and the provider work much better together if they have a pre-existing relationship or develop that. I've moved into the area. This is, I know that there's stigma around this. Which pharmacies will fill my prescription for my patients? And, kind of discuss those things up front. They may or may not be, dispensing very much, or I'm new to the area. This is how you get a hold of my provider group. Sometimes having a backline really helps, especially if you're a large practice and it's difficult to get routed to the right person in order to get things clarified efficiently. And you just want to have that trust and build that and understand, how best to work together.
Chris, you have anything you want to add to that?
So again, I think that collaboration with the pharmacist and healthcare provider are important, and having those shared intake forms. I mean, I know it's not always feasible for pharmacists to have access to, the electronic records of their healthcare providers, but having access to some information that's shared is extremely valuable. It's difficult for a pharmacist not to know a patient and get referred to that pharmacy. Certainly the pharmacist needs to talk to the patient, right? Communication is crucial. I always say that, as a healthcare provider, I don't make my decisions based on assumptions. I base it on evidence-based practice and working directly with the patient, with the providers and patients. And so that's how we need to practice. But having that shared information. So to Dr. Rhodes' point, obviously the provider who's seeing that patient has this information. So how do we ensure that it gets communicated properly with the pharmacy so we don't get those bottlenecks?
And I'll say one other thing about electronic scripts, which have really, enhanced safety and, getting those things over to us, with the information, where it originated. But it is a one-way communication tool to the pharmacy. So, we can't communicate back. So if it's sent to the wrong pharmacy and it's, unable to be filled there, it can't be transferred. And so, it does create, a new script. We still do have some, providers who don't have that in place. And so they need waivers. And we have some providers who want to fax prescriptions for controlled substances, for C3s, for buprenorphine. And there are just certain requirements that are rarely ever met on fax prescriptions by the provider. So those types of things, if you have e-scribing, that's great. It's great to use. But if there's a clarification, the pharmacy is still going to have to identify their appropriate, mode of communication for you, because we can't send a direct, communication right back to you to clarify things quickly. I wish it were
Right.
that case. I wish it were two-way.
Yeah, and that's a great point to bring up. You know, when a patient says, I choose this pharmacy to fill my buprenorphine prescription, that prescription gets electronically sent to that pharmacy, and that pharmacy doesn't have it. Pharmacies can't transfer prescriptions out. It has to be reissued as a new prescription. Do you know what kind of time barrier that puts on getting access to medication? It's just not in the best interest of the patient.
So do you have having that relationship and knowing ahead of time which pharmacies in your community have buprenorphine available then could alleviate some of that as a bottleneck? Is that what I'm hearing you say?
Correct. I mean, and the relationship with the provider. I mean, to me, it's a three-way relationship, right? So that pharmacy and provider need to make sure that they're coordinated along with the patient.
All right. Well, switching gears a second, I had a pharmacist who sent this question in. What is the Board of Pharmacy doing to help ensure pharmacists can uphold their corresponding responsibility? You know, if there is a prescription that has flags, I mean, so is there anything that the Board of Pharmacy is doing or planning to do that can help ensure pharmacists, do that and really, if you will, help level out the perceptions of regulatory risk, that a pharmacist may feel like they have related to buprenorphine dispensing?
The Board of Pharmacy, is protecting the public, and that's, and improving the health of the Commonwealth. So as a, in relationship to what is the Board of Pharmacy trying to do to help support our profession in order to, get these medications to the patients that they need. And we just reviewed and revised the FAQs, the frequently asked questions. I think you put a slide up in order to just clarify some of the myths versus fact, in order, for pharmacists to have the accurate information in order to dispense that medication, so they know, for sure what are the regulations that I need to be working within in Kentucky, and then, you're layering that right on what are the DEA requirements and federal requirements and making sure that you're compliant with all of those things. It's a lot different than, filling your amoxicillin prescription. So being familiar with that is truly important, particularly as this epidemic has, increased during our, pandemic. So, one thing upon another, and working with OIG and DEA. And I did see, I think we have some members of those organizations here on the call, and trying to work with them closely in order to make sure that that information's aligned and that we're, stating the same things, giving the same messages in order to be, aligned. So well, how are you supposed to be checking that script? It shouldn't be changing based on, which organization that you refer to. And so we did revise those. That we're still working through that and making sure that, those things are up to date. And just recently, nurse practitioners, can now write for refills on certain, C3s through 4s, right? So that was something new that we updated on the board page. But really getting that information out is important. So I would also say the community of pharmacy has a corresponding responsibility to keep updated as new laws change. And we're trying to send more e-blasts out as those things happen.
I have a question here from another pharmacist. There's a wide range of knowledge, stigma, and risk assessment, risk aversion among practicing pharmacists and technicians when it comes to buprenorphine. What would you recommend for pharmacy staff who need to work well as a team but have differing views and goals related to buprenorphine?
Well, I know that Dr. Harlow has a lot of opinions on this, so I'll keep mine short. you have to do what's best for your patient. And, barring any religious concern here, if your patient needs help and you're putting them, if that's the treatment, the MOED treatment that the provider has chosen for them is the best option, we should do everything that we can to ensure that they receive the treatment that has been prescribed as a legitimate use. Because those patients, may be at risk of relapse, and you're putting them in potentially harm's way if they don't receive the therapy that they have been prescribed, and they're going to seek therapy elsewhere, which may be unsafe for them.
Right. I mean, this is an important topic, and I have to say that to all pharmacists out there, there must be dignity in dispensing. Right. We need to remain empathetic with this patient population. Put yourself in the shoes of the patient. There was an article in the Journal of Opioid Management recently, and it really it was patient surveys looking at barriers to care, and while there were some that were outside of potential what pharmacists do, like transportation issues, these patients said that they felt like they were not a priority and were forced to wait longer for their medications because of their opioid use disorder. They felt like they were being judged. Half the respondents said they felt like they were being judged when they went to a pharmacy and got a prescription filled. They felt like the pharmacist didn't care about their well-being. Why would you as a patient go to a healthcare provider and you don't feel like they care about your well-being, right? I mean, this hits me hard as a pharmacist, because I'm sitting there thinking, this is not what I want pharmacists to look like. Not to mention the out of stock concerns that we've seen. So to me, it's so important that pharmacists remain empathetic and realize that these patients, their outcomes are determined by the people who treat them, right? If they're treated poorly, they're going to have negative outcomes, right? And we don't want that. We want these patients to get better. We know that there's more productivity when they're on treatment. And so there's so much that we could do as healthcare providers just by filling their prescription and giving them and having that dignity and dispensing, right? But get to know your patients, listen to their stories, find out who they are and why they want to achieve recovery. You can do that, and that's going to help improve their patient outcomes.
All right. Do we have other questions? I see a share in the chat, an article from 3 days ago on NPR's website that talks about MOUD prescribing in the ER. And I don't know if there's any other questions that people want to put in the chat. I have one additional one that I was hoping that Dr. Harlow, you or Dr. Rhodes could address. And that's related to policy barriers. Have you encountered, what would you consider to be policy barriers that you've encountered that may limit the stocking and dispensing of buprenorphine, and, any ideas on how those might be mitigated? And Dr. Harlow, Dr. Harlow gave testimony yesterday, so I have a feeling he has a policy issue that he would want to share.
Yes. Policies can be, there can be unintended consequences with certain policy. The policies that were implemented that help with pharmacists in Kentucky with a single PBM was a good policy move. But what happens is, there's certain medications like buprenorphine that are prescribed differently than other maintenance medications, and they may not be prescribed every single month. They may require tapering dosages. They may require short fills, and pharmacists are basically requiring to provide these medications for free and dispense these medications for free because of the policy of only having one dispensing fee per month. That wasn't the intention, right? I mean, it was never intended for that to happen. What happens is the pharmacy looks at that and they make a business decision. They say, well, of course I want to help these patients, but I can't provide a free service. Right, and it's unfair to ask a healthcare provider to provide a free service. Or it could even be worse, right? I mean, based on the current reimbursement scheme, it could be that you're losing money, right? So now we're asking people not only to, yes, we feel that you need to stock these medications, but you know what? We also need for you to lose money when filling these prescriptions to treat these patients. That's just not fair.
Are there, Dr. Rose, did you have anything you wanted to add to policy question?
Yeah, so, there's the lock-in, question with MCOs, and, there's a reason for that, and there's flags for that. But once a patient gets into a recovery in a maintenance situation, it can become cumbersome to overcome that. And in that situation, it is, causing, in certain cases, individuals not to be able to receive their therapy, or delay their therapy, which can be detrimental to that patient if they are unable to receive it in a time frame before they start to experience withdrawal, where they, then go to seek other therapy to curb that, right? That has been an area that we have been working directly with the MCOs, our team at St. Matthew's, and it may take a day and it may take 2 weeks, depending on if they have to reach that patient, the case manager. These are individuals who don't have phones or, they're difficult to reach, they're homeless. I think I saw a question about that, or they're transient. And so trying to get the patient the drug that they need at the time they need, when we have certain policies that are meant to, reduce opioid use disorder and, diversion, that has, unexpected effects. We have had, drug utilization reviews where patients cannot be on more than one MAT product at a time as they're transitioning from an oral to an injectable or back to an oral because the injectable wasn't appropriate for them. As they're trying to determine which MOUD treatment is the best for them, there are gaps in trying to get them that care at the time that they need it. And of course, you want to strike while the iron's hot, right? While they're still interested, before there's, we put them at risk of relapse. And so those policy changes were unintended. And, what has been instrumental for us is working directly with DMS and working directly with MCOs to resolve those issues, because everybody wants to be part of the solution. And I know, none of that's intended, but it does have harm associated with it.
So there is a question in the chat of following up on the question about the unhoused. How are you managing distribution to buprenorphine to those individuals? And are you requiring patients to pick up from the pharmacy? What if they can't physically get to the pharmacy? Any experiences to share in that regard?
Yes, so, there are patients who have requested help, Ubers or whatnot from the pharmacy. Actually provider offices have asked me this, and I'm sure they've asked Dr. Harlow this as well. How do we get the patients their therapy when they have transportation issues? And that is an issue if, they only have one ride to come to the pharmacy, and then, you have to go to another one because they don't have that product stocked. Social services is something I wish we had on staff at our pharmacy, and maybe something in the future to think about, if we were able to do that, but that's important. Meeting patients where they are. So, delivery services, of course, if it's an oral therapy, you have to dispense that product to the end user. You cannot dispense that to an office or clinic for pickup, directly, to leave it in the provider's hands for the patient to pick up later. So it's an issue. We've Ubered patients to our pharmacy before and paid out of pocket for that. And is that the right thing to do? We felt like it is the right thing to do if that's what the patient needed. But it is continuously a problem, especially as we've had more and more people unemployed and unable to, get where they need to go. And I do think that's where some of these other models help improve care, or, in the event of where we have a provider administered injection at the office, then we can do that per the new, in support with the interim role as well. So that allows at least the injectable product to be sent and given by the provider. It's one less stop to make.
All
Does
right,
that help answer that question, Trish?
I think so. I'm going to open it up to any other individuals. Is there any other questions from folks in the audience before we sort of try to round things out with some discussions of what's the strategy for helping us reduce stigma amongst our pharmacists, helping us address some of these barriers as best as we can to ensure the most access to this effective treatment that we know saves lives. And so any other questions from folks in the audience? Or any, I see any of the pharmacists I'm looking at, Dr. Johnson, or anything from your practices, any words of wisdom you want to share for any of the topics that have come up today? All right, so what's our plan? What's our strategy? What's the first thing we can do, Dr. Harlow, to improve access to buprenorphine in pharmacies? If you want people to leave with one idea today, what would it be?
Well, if I could just say this really briefly, because I know we have pharmacists and non-pharmacists on the present. I never know what to say in these Zoom meetings. They're here. So we have pharmacists and non-pharmacists present, and we're in Kentucky, right? I mean, we are hit hard by the opioid epidemic, but as you pointed out earlier in your presentation with your news clips, this is not unique to Kentucky. This is a national issue. So I want to briefly just state that the American Pharmacists Association has recently published their policy statements on increasing access. And if I could, if it's okay, just to read those 3 statements. So I think it's important for us to know kind of where APHA, the American Pharmacists Association, stands. The number 1, that APHA supports the use of evidence-based medicine as first-line treatment for opioid use disorder for patients, including healthcare professionals in and out of the workplace, for as long as needed to treat their disease. Number 2, APHA encourages pharmacies to maintain an inventory of medication used in the treatment of opioid use disorder to ensure access for patients. And number 3, APHA encourages pharmacists and payers to ensure patients have equitable access to and coverage for at least one medication from each class of medication used in the treatment of opioid use disorder. So again, my point here is that this is not unique to Kentucky. It's a national issue. Pharmacists across the country are being encouraged to have access and make sure we have equitable access to medications to treat patients long-term, as long as needed.
Dr. Rhodes?
So, a few things. We have, Kentucky is a primarily rural state. And as such, we need more X-waiver providers in those rural areas, as well as addictionologists, those wraparound services. We talk about therapies that they may co-administer or co-prescribe for withdrawal. And that's something that I think we need. We're looking at how many patients can be treated by an X-waivered provider. There is a limit. And, those things are, being evaluated and changed. But in order to fully address all of the patients that need assistance, I think that that's something that we can, certainly help promote. As far as, getting medications to where they, need to be in pharmacies to dispense, that is, something that we can help, promote and understand, I think, more why pharmacies are not able to either purchase it at the price that they need to purchase it at in order for it to make sense for them. So they're not losing money and they're willing to do it. But also, find out who is able to serve you, who is able to serve your patients. And then, if they are, what kind of other wraparound services they're willing to provide. Developing those relationships is going to be instrumental in helping your practice and helping your patient be the most successful. And having a really good relationship with the OIG and the DEA is also really helpful too. Like you want to make sure that we're working with them, so that they are aware of all the activities that you're doing and trying to be, as transparent as possible in developing a plan. And, we should be leading the way in Kentucky. We should be leading the way in new ideas and novel ways to approach care and meeting patients where they are, so we can show how effective and successful that working together can be. And I believe in us. I know we're doing it. And the research that we're doing today and the conversations that we're having today are going to make a huge impact. One step at a time, but that's my goal. And as the Board of Pharmacy level, if we can do something to help our community and help our pharmacists do a better job to improve access, I am all ears. That's one of the reasons that we did HB 219 in order to increase access to syringes and reduce transmission. And so, we are listening and we are supportive.
And I know many on the call are aware of House Bill 219, but some people may not be aware. But prior to this legislative session, pharmacies who sold syringes and needles over the counter had to maintain a logbook and had to query the individual, what was the use of the syringe, and record the individual's name and address in the logbook. And House Bill 219 amended the law and removed the requirement for the logbook and actually allows pharmacists to sell syringes and needles over the counter. And as long as they have available information for an individual about treatment resources and information about safe disposal of syringes and needles, and the information about naloxone and offer to give naloxone prescriptions. So we're very, very thankful that the board sort of led the charge with that this session, and we were able to get that important legislation changed. Jill Lee from OIG, do you all know if the DEA has relaxed regulations to allow for the HHS rule, expanding care by allowing any practitioner to prescribe up to 30 patients without SAMHSA training? So yeah, so that can happen. You can get the X waiver without having to show the education based on the federal rules, but Kentucky regulations still state that education is required, and it's a separate requirement in KAR 201 KAR 9270, separate from the X waiver. And so there's actually some dialogue right now, Jill, going on with KBML about that. And are they going to, since it's no longer required for up to 30 patients to have that education, is the KBML going to require the education as a state rule, because it's currently in their regulations as a separate requirement, separate from the X waiver?
That's a good question. We'll ask.
Yeah, and I think that brings up a valid point of these conflicting rules, right? You've got federal and state rules that can differ, and you have pharmacists practicing and providers practicing on these on the borders, and the borders, the states next to us may have very different laws, so, or slightly different laws where it's enough to be confusing, which can create additional barriers.
All right. Anything else before I turn it back over to Lisa to go over the CE credit requirements and reminders? If not, I'll just say on behalf of myself and Dr. Rhodes and Dr. Harlow, thank you for attending this afternoon. We hope you found it informative, and we hope you found it helpful to your practices. And please know that there were some questions that we received offline that were a little bit outside the scope of our discussion, which was really focused on community pharmacy. But if you posed a question and we didn't ask your question today, we'll be addressing that with you directly offline. Lisa?